I heard about your work, a surgeon applying agile ways of working in the NHS to theatre practice, and this is like catnip to me. I just absolutely had to know what was going on. So tell us who you are. What are you doing?
Yeah, what am I doing? What am I doing? So my name is Rob McAdam. I'm a consultant general upper GI and bariatric surgeon based at a trust halfway between Liverpool and Manchester, so not far from where we are today in Media City. Yeah, it's an odd thing to get into. I think me and my mate are possibly the only clinicians who are also qualified Scrum Masters as well. And we both got into it because we started a few years ago now, pre-pandemic, looking at a project around digital consent. He's an anaesthetist, I'm a surgeon, and we thought this is an obvious thing to be looking at. Now, that project didn't go anywhere, and that's fine. But what we did do is worked with some software developers, and they used an online Kanban board, Trello, that I think quite a lot of people have heard of, and ran the project because we were sort of distributed all around the country using that. And although the project didn't get anywhere, I thought this really makes a lot of sense, meeting every couple of weeks and seeing how the project's progressing and bringing everything together, making it very visual. So I kind of asked the software developer, where does this come from? And he said, it's agile working. We use it all the time in software. I'm being somewhat curious. I started, picking up a few books, and I think the gateway to all this was the Sutherland Red Book, how to do twice the work in half the time, which for hard pushed NHS consultant seems a good place to start. So we kind of and I found that really accessible. I thought it was a really well written book, and kind of went from there. So that was the kind of gateway into it, and the first practical use really was at a time when I was clinical director of general surgery at my trust. Now, it sounds very grand. It's not. It's the lowest level of kind of medical management, but it does mean you're line manager for maybe 60 doctors,
right?
Which is a reasonable chunk of people, and certainly a reasonable chunk of additional work. And one of the things that NHS England dropped on us at short notice, which was they tended to do, was that they needed a pathway for particular patients, some of our sickest patients that come in needing major surgery, major abdominal surgery. And the way they leverage these things, or tend to, is to say, unless such and such is done, the tariff that the hospital receives is not going to be the full tariff. You're going to lose a bit of money. We want you to do something, and we're going to incentivize you in this way. So this was a bit of a burning platform, but it was a really complex project in as much as it involved people in A&E, people in ICU, anaesthetists, surgeons, geriatricians, because it was all around older patients. And we were really, really struggling to get everybody together. Everybody was busy, and we couldn't get a date in the diary. So whilst that was going on, I actually set up an online Kanban board, an online Trello board, and we worked as a disparate team and collaborated using that, I guess, agile approach. And in the meeting that eventually got scheduled when everybody could make it, we presented the divisional director with the finished product that we'd already iterated 2 or 3 times and agreed on. So this was a bit of a kind of mic drop moment. It's kind of like, well, we've all got together. Let's discuss this project. And the team went, no need, we've done it. Right. Where did that come from? That was, and what's this about? So that was my first introduction, if you like, to using it in an NHS environment. And I found it really accelerated some of the stuff that goes on behind the scenes that patients don't need or don't want to see, but sits behind all the services that we provide.
So tell me about some of the other experiments that you've run, because I think they're so tangible and would, I think, make sense to people that are working outside of healthcare as well. So talk to me about some of the experiments that you've run since, and what the outcomes of those experiments have been. Yeah,
well, we've done a number of different things. I can talk about our pandemic experience if that's of interest, because the next thing along the lines, having done the work that we did in developing pathways and standard operating procedures, we presented that. We were the first hospital to present at a national meeting and get it published in abstract form, to kind of resounding indifference, I think it's fair to say. I never actually met. It was a meeting in Telford. Nothing against Telford, but I couldn't make it actually. And the slot where one of my colleagues was presenting it was one of my junior colleagues, was like 9:00 on the day after the night out, and I think it was him and a couple of stray dogs, and that was about it. There wasn't a huge amount of no ripples. But we were there first. But things really came into their own during the pandemic when everything was turned upside down in a heartbeat. So from running a department of 60 people in a traditional way with traditional rotas and forward planning and all that, we suddenly lost about 25% of our staff in a heartbeat. Not always the same 25%. There was a significant chunk of people who, for chronic disease reasons, never came into work for about 6 months. But others who were either acutely ill or self-isolating because there was somebody in the family that was testing positive. And you forget what that was like. I think we've all been reminded this week because the reports just dropped of how really challenging it was at that time. And we sadly lost one of our orthopaedic middle grades early on it was one of the first healthcare associated mortalities from COVID. So it was a really, really difficult and dark time and challenging to keep things going. And what I found was the obvious thing seemed to do would be to flip to an agile way of working because nobody was really quite sure what resources you were going to have at short notice. So instead of doing all the traditional forward planning, we flipped and we had daily stand-ups. We had a daily meeting at 8 a.m. where we looked and saw who was in that day. And then we fairly ruthlessly prioritized our workflow. Mm-hmm. First job was obviously to keep the doors open and keep emergency service going. Second thing was to make sure we were looking after safely the existing patients that we had on the ward. The third priority was actually looking after our staff. So if somebody looked exhausted or had been working over the odds, we'd send them home. The next thing we did was adopt some of the principles of self-organising teams. So we said to our most junior doctors, instead of doing the kind of traditional, this is what I want you to do, said, well, you're all a bunch of bright, sparky 22-year-olds. Go and find some useful work to do and work it out between you. And they were like, yeah, fine. Yeah, no problem with that. And then we were able to have some staff left over that we were donating some juniors to our intensive care unit and our emergency department because we were fairly well organised. And lastly, we've got some really, really excellent colorectal surgeons who were desperate to keep their cancer service going. And with the assistance of the way we were working, we were able to free them up, plus middle grades, to go and assist them. So fairly uniquely, we actually maintained our colorectal and some other cancer services going throughout the pandemic. That was recognised in a parliamentary award a couple of years later, 2022. The Trust won Excellence in Healthcare at the National Parliamentary Awards, which was very nice. Now, I'm not suggesting that wouldn't have happened if we hadn't flipped, but it certainly helped us. It really, really helped us. And I'm tempted to quote the words of one of your colleagues, Matt Barnaby, who was kind enough to give us a seat at a couple of us a seat at the training that BASIS offers. And one of the things that he said that really, really resonated with me was when the situation is more unstable, the cycles need to be shorter. Yeah. So we were essentially running our service in 24-hour sprints, 24-hour cycles, because we couldn't realistically predict what resources we were going to have, from one day to the next. So why try? And the penny dropped really for me when I met one of the other clinical directors of a similar sized department in the corridor shortly, sort of midway through the pandemic, and he said, "How are things going for you?" And I said, "Well, obviously challenging, but okay. We're keeping our heads above water." And he said, "I'm having an absolute shocker of a time because I do one rota and I then rip it up the next day. Yeah. And then I do another one and then I rip it up the next day." And it just dawned on me. I was like, well, why are you doing that? Yeah, why even do that? But I think this speaks to the kind of mind shift that you get if you start thinking in agile terms. Then you start realizing that doesn't actually make a lot of sense in a really chaotic and unstable environment to be doing all that forward planning only to discard it. So that for me was the moment at which I thought, right, okay, this really has something to offer. But thankfully we're not mid-pandemic, very often, and there's maybe we'll come on to it. There's some stuff that we learned that we possibly have lost and should be adopting a bit more. But that led me to get in touch with JJ Sutherland via LinkedIn, and in a slightly embarrassing sort of fanboy moment, just write him a message saying, I really like your book, and by the way, it's really helped. Just for your FYI, you've written a book that's actually really contributed to some tangible things that have made difference for patients. And he was good enough to answer me, and we've ended up sort of, I wouldn't say working together, but he's put me in touch with some of his colleagues at Scrum Inc. And for the last 6 years or so, we've been trying to see how Agile might work in some aspects of the NHS, which I think we all know really needs some major interventions at the moment if it's to survive in its current form.
If you're still here, my assumption is you're finding this conversation useful. We're recording these interviews because we think it's important to share stories of people who are leading and designing more human, impactful and relational public services, and we'd like as many people as possible to see them. If you think you can help us with that, then I'd be so grateful if you did one of three things. You can just like the video, and that'll help other people to find it in future. You can leave us a comment and let us know why you stuck around, or you could subscribe to the channel. And honestly, I've got no good reason for that other than it would cheer me up. Okay, back to the interview.
Well, I'm interested to talk about some of those interventions because most of our work, as you know, is in local government. We do some work in healthcare as well. And I think almost universally, the people that we talk to that are interested in working in an agile way are frustrated because during the pandemic, the penny dropped for so many people. Oh, wow. It doesn't really make sense to work in this linear way when we're dealing with so much turbulence. We really do need to shorten the feedback loops. And they just sort of acted themselves into a new way of thinking, started working in a much more agile way, but then have seen working practices revert back to how they were pre-pandemic now that the context has changed. But what's really interesting about you is that you've taken that momentum and you've tried to do experiments. I mean, I hesitate to say in stability, but relative stability by comparison with the pandemic. So let's talk about some of those other interventions that you've tried since that point.
Yes. So the significant thing for me was when I was organising some slides actually for an introduction to Agile for some of my senior leadership team at my trust. So I'd talked about how useful we'd found it in the pandemic, and on the back of that, I organised a webinar. Being slightly pushy and not knowing my limits, I just kind of phoned, Whitehall and said, you guys seem to be doing some interesting stuff in Agile, which I'd come across in a meeting where a guy called Mike Waring, who is Director of Defence Design, was presenting. And I thought it was really, really interesting. So he and Rear Admiral Paul Beattie came on a call, and my senior leadership team joined that. And I had to, something of a newbie, sort of introduce the subject. And I thought, I'm just going to embarrass myself here. I don't really, these guys have been implementing Agile throughout a massive organisation. They've got loads of experience and loads of stories to tell. I've just got, sort of the naivety of the enthusiast to introduce. So I thought, well, most of my audience are sort of largely, I would imagine, ignorant of Agile and Scrum. So I'd probably need a graphic. So I pulled one of those graphics, the sort of thing that looks circular, feeding into a loop and a Scrum team and the rest of it. And so I thought, I'll just sort of explain this. So as I was making my slides, it dawned on me that the stable Scrum team, the objective done, the things that are completed and the definition of done, the working from a prioritized backlog that draws from a longer backlog and is prioritized according to business need, actually really reminded me of the best bit of my job, which is the time I spend in theatre.
Yeah.
Because it maps across reasonably well. When we come together for a theatre list, we've got a stable team that stays together for the duration, half a day, whole day. We work off a list that's been pulled together that's right sized, if you like, for the team and the time. And that is pulled in turn from a wider backlog. In our case, what we call a PTL, patient treatment list, or colloquially a waiting list, which is prioritized according to clinical need, not business need, but clinical needs. So obviously, the people at the top are the cancer patients and people with urgent issues, and that's constantly being reprioritized, just in the way as an industry would have a backlog that they're working from. And the other thing that we have to do at the end of the list, it's mandatory, is a form of a debrief, which is not dissimilar to the ritual of the retro.
Yeah.
So I thought, well, this is actually, it's really quite striking.
And this was just occurring to you as you were talking.
Yeah, it did. Yeah, I was like, well,
that was a handy analogy.
It was a bit of an aha moment, and it was like that. And perhaps it shouldn't have been a bit of an aha moment, because Jeff Sutherland, I later discovered, one of the co-creators of Scrum, as you know, has got a clinical background. He was actually a professor of radiology at the University of Denver, or somewhere in the Midwest. And some of the work that Scrum Inc. has done has been in clinical environments. So anyway, I sort of put this across as a kind of hypothesis, and I thought, I'm super clever. I'm going to solve this issue immediately by everybody's going to go, of course. Why didn't we see this before? And so I did this kind of exposition of why I thought it was a good fit, and then there was a pause, and then Rear Admiral Beatty said, "Yeah, we find that a lot." And I was like, completely deflated. I was like, "Oh, really? It's not novel and new and exciting?" No. And he just said, any situation where people are allowed to work together and as effectively as they can tends towards this kind of organization. This is just how humans tend to like to work together.
Yeah.
And he said, we find similar little clusters of that kind of thing going on in successful bits of the military and successful. I mean, I guess you could think that through. Lots of smallish teams working together for fixed periods of times are high performance teams in sport, in the military, and in all these areas. So it's an insight, but it really struck me that it was a potentially important insight, particularly because. It's no surprise that the NHS is under pressure to perform for the money that's put in. Again, this week there's been a report, hasn't there, from the Commons Public Accounts Committee that says that there's not a huge amount of correlation between the amount of money that goes into the NHS and the amount of results that it produces, and that's a bit sort of counterintuitive. So I looked at this and I said, right, okay, fine, this does map across quite well. If we thought about a theatre session, for example, like a Scrum team, and we know that Scrum teams seem to work, maybe 4 to 10 times more effectively than other ways of working. If we kind of put the model of one over the other, what would we do different? Yeah. If we said this is like a Scrum team, so what would we do different? There were 2 areas. One is that we would be probably more specific about the size of the tasks that's going into that sprint planning process, or the list planning for me, the list planning, the better to use the time that we've got. And the second bit is at the other end of the theatre list. We do a debrief, but in most situations, it's not particularly in depth, and it's mainly focused, as it should be, on any safety issues, because obviously if there's been an incident, that needs to be reported up, and there's a whole governance pathway that sits behind that, as there will be in social care, I'm sure. So we do the right thing if there's been an incident, but we don't actually think about how we've worked. We don't routinely just spend 5 minutes at the end of the list and have a conversation about how could we have done better, what little things might we have changed that would have improved things. So that's our hypothesis, is that if we look at those 2 bits, they're the 2 standout bits. No, I'm sure you would agree in your environment and in any other environment, don't touch the team. The team is fine. The don't tell the surgeon how to do his operation, or the scrub sister how to set a trolley up.
Heaven forbid.
Whoa, yeah, angels fear to tread and all that. Certainly don't tell the anaesthetist, what kind of anaesthetic to give. That there's lots of reasons why practitioners should be left to do, what they're good at, and that's fine. But I guess it comes down to, there's been books, isn't there, sort of entrepreneurial books about saying you're spending time thinking about being in the business or working on the business, if you know what I mean. We as clinicians are so focused on actually doing the job that we don't take a step back and ever give ourselves just the time to say, well, how could all of that been made a bit easier? How could have that been made a bit slicker? How come we're making we're hitting the same buffers and delays and irritations time and time again? And that's the offer, I think, that Scrum has, is that if you systematize that, if you do it regularly, and if you cure some of the recurrent small issues, those things get banked like compound interest. So next time that won't happen. You'll surface some other things, but you'll be going a little bit faster, and the day will be a little less challenging, because there's nothing more exhausting than a day in theatre where you're constantly firefighting and reorganizing things, and that's where errors happen as well. So I'm all for easier, more productive, smoother days in theatre, because they're the best.
So talk about the lists and right sizing them, because what you're talking about there is, I suppose, using some kind of collective intelligence to estimate how long we think these things are going to take. So what was happening before and what happens now?
This is really interesting, because we have a list planning process. We have an admissions process. Everything with big hospitals, clearly have to have different departments that do different things. So the standard way, even now, of estimating how big an operation is going to be, or how much time it's going to take, is literally a tick box on the back of a listing form to the nearest half hour.
And who's doing that?
Whoever is seeing the patient and listing them. So it could be me, or it could be somebody quite junior that my secretary's rung up and said, so-and-so's called in sick. Could you spare an hour in clinic? And they've come down, and it's the first time that they've done my clinic, and they don't know too much about what I do, but they're confident enough to put. So there's all sorts of errors starting to creep in beforehand. And then you get on to things like pooled patients, because it's a bit like the queue in the post office. It's easier to have one pool queue and then pull people into the event. That's much more efficient than sitting in individual queues. So we have quite a few patients for common operations that are pooled amongst surgeons, and then that backlog is pulled through into the next available list. So there's no guarantee that you or your team even has seen patients that are on. So we're all working off information that's fed into the system right at the beginning. And if that's slightly or even grossly wrong, that just gets propagated, sort of garbage in, garbage out principle.
And when you say wrong, you mean this is actually going to take way longer or way less time?
Yes,
Right,
exactly.
okay. Yeah.
So we did a little study on that, because allegedly all surgeons and clinicians are scientists, so respond to data more than anecdote. So we thought, well, what's the best way of looking at this? So let's look at 50 patients listed for common operations, keyhole removal of the gallbladder, which is probably the commonest one that as upper GI surgeons we do. And what we found is that consultants tended towards underestimating the time that it would take them.
Ooh.
No false modesty, you see. That's the thing.
Oh, brutal.
It will be out in a heartbeat. Yes, that's right. So there was a tendency for them to underestimate, but there was a tendency for junior doctors, can't call them junior resident doctors, to overestimate.
Yeah.
Because there's more of them than there are of the consultants, if you get a sort of mixed list, it becomes largely guesswork, roughly ballpark, but you can get big errors. And the best example of this was a list that I did. It was a whole afternoon, so 1:30 till 5 o'clock, that we had 2 cases on, and we were finished by 3:30.
Right.
Now, I'm a relatively quick surgeon because I've been around the block a few times, and had a quick anaesthetist with me that day, and we just we actually went back to the original listing forms and said, we're just wasting precious time. You've paid for the heating, the lighting, the staff, everybody's paid to be there, and yet we're utilising probably 45% of the available operating time. That's a luxury we can't afford. So we went back to the original listing forms, and one procedure was listed for 1.5 hours, the other for 2 hours. Now, admissions will book a list for 3.5 hours. So they had got it absolutely right with the information that we had fed them.
Yeah.
But the information that we had given them bore no relation to reality at all.
Okay.
And we thought, well, this is not the 1940s, it's the 2020s. We must be able to do better than that. The data, we're in a sea of data and a swamp of data. Everything you do in theatres is tabulated and entered into a management system. We must be able to use a bit more logic and a bit more science. So that led us down the route of starting to look at large volumes of data, plotting histograms for common operations, and actually doing some kind of rational work about, let's be realistic about this. Let's plan a list according to what actually happens for this particular surgeon under these circumstances. If you do that, you actually find that you're far more effective at filling the time.
So you're looking at the literal time surgeons have taken to do these operations in the past.
Yeah.
And then using that data to inform the list planning in the future.
Yeah, exactly that. And that and interestingly, and we're very embryonic stage, so we watch this space, but all the hallmarks are from the original, the early work is that this is going to be quite powerful. Every single surgeon that I've shown this to wants to know, because I think surgeons are naturally curious, and they're also favourite subject is very often themselves. I put myself in that way. That's very rude about surgeons. But no, they are reflective and invested. God knows you shouldn't be doing the operation if you're not those two things. And if you show people their own data for their own work, they are really curious about it and want to know and want to be a part of that process, because sometimes, with the best will in the world, the data that the NHS collects is, shall we say, not of the highest quality.
Yeah.
And ultimately, we carry the responsibility for using those resources. I mean, this whole project was kicked off by the fact that one of my colleagues in management sent me a kind of jokey text saying, I'm going to have a word with you because all your lists are underrunning. And I was like, well, this is confusing. I only do what the management put on the list, what the hospital books for me. But I am probably a bit quicker than many surgeons, and the errors are compounding, and it means that I'm underrunning and I'm not using my resources, and that comes back to me. So where are you getting your information from? When these things are booked, and the information was just coming from these bits of paper. So if we can get better data, I think we can do better planning. And of course, the way in the 21st century to do that is to not necessarily run the numbers yourselves, but to utilize artificial insemination. And I wouldn't use. I don't think that's a very. That's a really bad idea to use artificial. So yeah, that's right.
I mean, reading between the lines, I think you were going to say AI.
Yes, quite. I was building up to it then.
So, and I think you're experimenting with this, aren't you? Within a closed sort of data set within the trust.
Yes, yes, yeah, we absolutely are. And the interesting thing is that if you can think of your operative times as a normal distribution, as everybody who does practical things knows, sometimes the thing that you do will be dead straightforward, and other times you'll struggle and things will slow you down. But that's not as chaotic as you might think. If you do enough of them, you'll begin to show that skewed normal distribution. And I'm not for a moment suggesting that we schedule everything so tightly that you only work off the mean of all these procedures. You can build in some comfortable gaps by perhaps using the mean plus one standard deviation or two standard deviation, however you want to do it. We're just tweaking those things at the moment. because, and this comes full circle back to some of the principles of Scrum that we were talking about. I'm all for utilising really precious NHS resources as well as I possibly can, but not at the cost of the staff, if you know what I mean.
Yeah.
You know, the surgeons, I think, will be fine with it, but we've got to remember that we're working with human beings who are scrubbed in theatre, who've got other stuff going on, the anaesthetic assistants, the operating department practitioners. They have a voice as well, and they're equally important as to have you had a good day. And really interestingly, all the evidence suggests that the sense of satisfaction that people get from a slick list that's gone well and has been well planned and fills the time appropriately is significant, and people like that. I think the general principle that people like to come to work and do a good job and feel at the end of the day that things have gone really well and have flowed nicely is what we're aiming for. So we're starting to roll this stuff out and do some actual kind of structured trials, and we are looking at what they call, the operational research is called balancing metrics. So, we're going to measure staff satisfaction and make sure that that's not compromised. We're going to measure on the day cancellation rates to make sure that we're not bringing people in and then cancelling them at the last minute because actually we got it all wrong.
Yeah.
And all of those kind of things are, I think, super important. So we're not pursuing efficiency at all costs. We're doing it gently and proportionately and responsibly. But I think there's the prospect of some real breakthrough gains.
So what are the initial findings? Are you finding that you're able to do more surgeries?
Yes.
Yeah.
Well, this is where it gets interesting, and it again draws on the Scrum principles. You may find it slightly strange, as I do, that the NHS, the way the NHS analyses operating lists is largely by time. Mm-hmm. So they've got this concept called capped utilisation. In other words, you can't just keep operating all night and do 120%. It's capped at 100%. But the target is that overall a department should be delivering maybe 85%, 75, 85% utilisation of the resources. But what there hasn't been historically is any attempt at quantifying the actual work delivered. So you get into the really strange paradoxical situation whereby if I do 3 cases and finish 20 minutes early, it's underrun.
Yeah.
If somebody in a next door theatre does 2 cases, exactly the same as the kind of thing that I was doing, and finished exactly on time, it hasn't underrun, and therefore that list gets a tick and mine gets a cross against it. So in the same way that Scrum encourages people to do that kind of planning poker thing at the beginning and actually talk about the quantum of effort that's required to do something, we're starting to introduce the idea of surgical story points, surgical points, which is getting the experts in the room, the surgeons, to say, right, okay, how big an operation is this? How much bigger is this operation than that one in relative terms, and do that relative sizing exercise. Yeah. Importantly, that's not so that one surgeon can say, I'm doing 50% more work than you. It's so that we can start sort of rationally planning those lists in the same way that Scrum teams can do. So as a kind of pathfinder with this, I've said, well, I put my money where my mouth is. Let's look at the kind of things that I do in my practice and assign them some points. So a small umbilical hernia would be 3 points. The massive paraesophageal hernias where half your stomach's in your chest and, all that kind of thing that takes half a day to do laparoscopically, 21 points. And we use the Fibonacci scale like is recommended. And what's really interesting over the course of this year is doing that. I've started to move towards, with my booking clerk, saying, right, okay, instead of, as well as time, let's look at the amount of points that we're actually delivering. So the work that we're delivering, not just the time that we're using. And if you do that and you slightly push the envelope and say, that was comfortable, can we go a bit further? I've gone from an average of 15, 16 points per session, half-day session, up to 21 points per session. Now, if you just looked at utilization, you wouldn't necessarily notice that, but I'm doing possibly the same amount of cases, but they're more complex. Or they're the same complexity and there's one more on the list than there would have been, around Easter time. And I'm trying to get people to adopt this, and they're starting, and certainly the surgeons are starting to get it. There will possibly be a bit of friction having that, having the conversation about, relative sizing, relative, for procedures. Some people will do something, some people will do others, but that conversation is going to be really interesting.
Well, that's where the interesting conversation is to be had, isn't it?
Yeah, I think so.
And it's in the difference that we get closer to the reality.
Absolutely, yeah. So we're going to start having those conversations in different specialties and say, okay, for orthopedics, so if a standard total hip replacement is 8 points, what's a revision hip replacement? What's a reverse shoulder? I'm not an orthopedic surgeon, so I don't. But anyway, all these kind of super complex stuff. Where does that sit? And again, importantly, it's not, as I'm sure you would agree, it's not about comparing apples and pears. It's not comparing Mr. Pink with Mr. Brown with Mr. Blue. It's about an individual's team saying, right, this is comfortable for us. That was okay. We tried to push it, that wasn't great, so let's drop back down again. And the kind of yesterday's weather thing, how did it go when we did such and such? Yeah, that was fine. I'll give you a very brief example. I did a list this Monday, so 5 days ago.
Yeah.
And we've kind of gently increased the story points, the surgical points. And this was a 3-session day, so it was 8 a.m. to 8 p.m. Now that's really, as you might imagine, it's much more difficult to predict a list that's 12 hours long than it is 3.5 hours. Yeah. That's easier. The errors go up the longer you're predicting for. But I looked at it and I thought, well, let's see if we can get 21 points done per session. And we did. We finished absolutely bang on time. But our operating department practitioner had gone because his day's work finished at 5. So we all, at the end, we had a proper debrief like we were talking about. Yeah, let's have a proper debrief. How's it gone? Yeah, great. It's been a really good day. We've got loads done and it's marvellous. And I just said, I thought our ODP looked a bit too busy. And the person who'd come in to replace him said, well, before he went, he told me that he's only had 20-minute break the entire day. So that was it. It makes 2 points. One is you can't push the team too hard. There's solutions to that. We might be able to say, look, if we're going to do this, we need an extra ODP, or he needs to have lunch relief or something. But also, if we hadn't had that detailed debrief, that would never have come to light.
Of course.
That would never have come to light. That would have been gossip and possibly a bit of grumbling in the tea room, but it would never have been surfaced. So having that formal little ritual at the end, how is everybody? Let's check in. Was everybody comfortable with that? If not, say so. And this guy said, well, I won't mention his name, but before he went, he said, I'm a bit shattered actually, because I've been running around like a headless chicken all day trying to sort things, get the patients. And it was all legitimate work. It was all the work that, because it's complex stuff, when you're doing morbid obesity surgery, you have to position people and all that. So, he did a great job, but I think he was shattered at the end of it. Perhaps
not sustainable.
No, absolutely not. Yeah. No, absolutely. And that's what worries me actually, is that occasionally you get places that within the NHS that are piloting things and sort of trumpeting things called hit lists, high intensity theatres, and they're kind of like, wow, this is the next thing the NHS is needing to deliver in spades. This is the way we do. We're going to put 25 of these things on a list, and we're going to crack through them. We're going to, and you just kind of think to yourself, is it sustainable? Is it exhausting people? Is it burning people out? And that's a worry.
Yeah, which completely defeats the point, doesn't it? I mean, it's all well and good having a great day in theatre, but if that's not replicable because people are burnt out or they go off on sick, then you lack the consistency, and overall over a longer period of time, then that efficiency that you gain will be lost and it'll leak out
completely.
But I want to come back to the retrospectives, because that's a really, really great example. But just to wrap up this the sort of idea of surgical points, what it sounds like is the early sign is that more surgeries are being done, which means of course, people having their surgeries sooner, better outcomes for patients, but also my assumption is savings, that the list is getting done much more quickly. Is that fair to say?
Yes, it absolutely is. I mean, I think it's fair to say that most trusts are behind their activity plans.
Yeah.
And there is a strong push to try and maximise the assets that we're using, and the upside of all these things is really, really highly significant. I do have to say though, and I'm really heartened by this, certainly in our trust, if you talk to the finance department, they are not particularly interested in talking about finance, if I'm honest, which and they would much rather talk about patients being treated. And the quote that I get very often is, we take care of the patients, the finance will look after itself.
Yeah.
And I found that really heartening. I thought that was great, and I've got a lot of time for that attitude. So, the more patients we're treating, the less time people are spending on waiting lists, as long as we're doing it safely, without burning people out and without compromising, without cutting corners and those kind of things. I think that's a win-win-win. It's a win for the staff, it's a win for the patients, and it's a win for the trust and the broader NHS, because this is public money that we've been entrusted with ultimately, and it's it needs to be spent wisely.
Yeah. Let's talk about the retrospectives. So how that was a great example of how something was surfaced that you can now act upon.
Yeah.
How are you going about? I mean, literally, how are you doing the activity of the retrospective in a way that's different to the debrief? And then when you identify things that didn't quite go so well or small improvements that you want to make, how does that actually happen and not get lost?
Yeah. So as I say, there are some safety guardrails part of any invasive procedure, and one of them, they're called NATSIPs, National Safety Standards for Invasive Procedures, and one of them is a debrief at the end. But it has to happen, but it's not specific about how what components there are, and very often, too often, it's kind of like it was anything for the debrief. No, as shouted down the corridor, or somebody sort of wheeling out, getting the jacket on and heading out. So what we did, trying to push this initiative in a very kind of light touch way. The first thing, rather than trying to change anybody's behaviour, is just to look at the documentation around that, because on the back of the big A3 sheet of paper, which is where the patients and what procedures they're having is written, on the back of that is a box that says what went well, what went badly. So the first thing we thought was, well, let's just harvest that information and pull it together and see. So it's these days the AI can do that for you very easily. So we just simply took all the information from a week's worth of debrief documentation in the trust, and we fed it into the AI, and immediately that gave us a kind of ranked list of things that were problematic. And again, this is not anything that was a kind of potential patient safety issue goes up a different pathway. Quite rightly so. Governance stuff goes to governance, and just to reassure everyone, that happens very often, and it's usually very minor stuff, sort of. But if there's a near miss with something, then that goes that way. But this is just the kind of low level grumbling things, the niggles, the got a slightly late start because there wasn't anywhere to see the patients on this particular ward, or the ward staff weren't ready, or the patient was a reproductive age female and they hadn't had a pregnancy test done, and we checked and this was wrong and that swab was. It's all the kind of little glitches, and if you do that across a whole department for a week, then you start to create yourself what you might say in Scrum terms is a backlog that's making it real. It's all about Agile's making the invisible visible. It's starting to make the things that are going on everywhere that everybody kind of shrugs their shoulders and says, what a shame. Starting to make it more visible. And then what do you do with that? Well, what we're hoping to do with that is to encourage teams to fix the stuff that they can fix themselves, which is some of the things, and obviously, like everybody, there's some really resourceful people who come up with ideas and changes. There's some stuff that would be requires capital investment, or that's never going to happen. And if somebody says, "Oh, we need a helipad on top of the building so that we can," that's never going. Do you know what I mean? It's kind of like there's the occasional grandiosity that's in there, not often, but there's that chunk in the middle that, with a bit of work, we might be able to address. So that's the bit that's fertile ground for actual traditional service improvement. But unless you actually start collating and harvesting and aggregating that information, it becomes hellishly difficult to go to the finance director and say, please fund this.
Yeah.
Because it's money that's dribbling through his fingers, but he doesn't see it because nobody's showing it to him quite how much it's impacting what he can deliver on for patients on a day-to-day basis. Just to give you one little story of how a really, really tiny improvement. So, as I say, I do a list that's 12 hours long, goes on till 7:30, 8 o'clock at night. And we had a patient listed for a general anaesthetic in the evening session, so 6 o'clock at night. He'd come into hospital sort of mid-afternoon whilst we were still operating. So me and the anaesthetist had gone out to see him on the ward. Now, this was a chap for a GA procedure who had learning difficulties. He had Down syndrome. And the anaesthetist saw the patient and said, Down's, I'm not an anaesthetist, so I don't really kind of know this stuff, but he said well, the Down's patients can have difficult airways. Right. Because of the kind of morphology of and she said, I'm not sure it's the right thing to be doing, to be giving him a generalized. If I get into a difficult airway problem, I've nobody else around. We're on our own here in the department. Yeah. Everybody else has gone home. So we would ordinarily not do that. Okay, fine. So we went and saw this chap and his parents. And of course, he'd come into hospital. They'd taken time off to bring him. He'd fasted all day, got changed, sat in the bed. And we went in and said, terribly sorry, but we're not going to proceed today because it's not the right time, which by anybody's estimation is a really poor state of affairs. And we came back and we did a proper debrief at the end of that list. So we talked about it. And I promise you may be surprised, but for the most part, that kind of thing happens. Most people kind of roll their eyes and shrug their shoulders and go, and because there's so much else going on, we don't have time to think about what's happened in any depth or detail. But we've got into the habit by this point of having a proper debrief. And we've started experimenting with using AI again to kind of feed the debrief information in. Now, this is all secure within an NHS environment. It's not ChatGPT. It's something that's been signed off as safe to use within the NHS. And when we did the debrief and we kind of recorded it, the suggestion came back is do the admissions department, would they benefit from some guidance on when to book these patients? And I'm ashamed to say that had never occurred to me. And I thought to myself, well, maybe I'll ask them. So I actually sent an email and said, just FYI, this chat was cancelled. And it's because da-di-da-di-da. Would it help if I set out some sort of standard best practice guidelines? And surprisingly, the manager emailed straight back and said, that would be really helpful. Reason being is that a load of our really senior admission staff have recently retired, right. Got a bunch of new people in, and this kind of implicit knowledge that's not documented anywhere, but people who worked there for 20 years would know not to do that kind of thing. It just isn't there. It's gone with them. So yes, please put it in. So what anybody would do in these days, you ask the AI to write you a set of standard, and you tweak it and you make sure it's happy, sent it off, didn't take any time at all. And just a couple of weeks ago, I heard that the edict's gone out within my trust that please can every surgeon do the same because they've found it so helpful. Now, that is one tiny thing. Nobody's going to notice that we don't get Downs patients booked on the evening session anymore.
These things compound over time, don't they?
Exactly. That's one problem that we hope not to have again. And then we'll move on to the next one, and then we'll get it. So it's that kind of approach, I think, that's really helpful. So yes, big tick for doing a debrief. big tick actually for the AI, feeding it into an AI and saying, what do you suggest? What possible things could we do to prevent this from happening again? And just having a go.
I think it's wonderful. One of the challenges that I often get when talking about working in more agile ways, particularly in services where perhaps there really is a question of life or death, or we're dealing with very vulnerable people, is people's assumption is, well, surely it's just really risky to be testing and learning. And my response back is usually, well, it's risky not to be testing and learning. And you've got to remember that, you're still Rob McAdam, consultant surgeon. All of that knowledge about what is appropriate and safe to do doesn't just go out of the window. This is you in control and trying to identify opportunities for continuous improvement. And that's just one very simple example of how putting this agile way of working into place can make small improvements that just compound over time. And I think it's really, really heartening. And also a great example of a use of very safe use of AI with you in control of that process. Just using it to optimize how quickly it's produced.
I do think this will become really important, and like with all AI models, it gets better the more it's used.
Yeah,
but I completely agree with what you're saying, because the prospect of making any interventions in a social care environment would terrify me. I would much rather take somebody's esophagus out than give an opinion on risk in that kind of scenario. But it's because you're you and I'm me. Do you know what I mean? And you become accustomed to those kind of situations. And you're right. Again, coming back to this, with the estimation thing, trust the people with the knowledge, trust the team to know what the appropriate thing to do is. There is governance around this. Absolutely, there should be governance around this. Our use of AI has gone through an extremely rigorous process. And it will continue to do so, and we've got all the guardrails and checks and balances in place. So we're doing it the right way. But I think this could actually make a difference to real frontline deliveries. This is not an abstract kind of AI concept. This is actually what we do on a day-to-day basis. And if we integrate it well, I think it will become standard practice going forward.
I think it's a great example. Some research came out of MIT very recently, which you may have seen, about AI tests. And so it's something like 95% of tests with AI fail. But that's okay, because it's all learning. And what's important is that the test is relatively small. There are quick feedback loops, and we learn from it. And this is one of those examples where, it's a relatively small test. It's within your control. There are very quick feedback loops, and we can scale on the basis of learning. So yes. I think it's brilliant. I'm interested to ask you about what feels incongruous now about the way things were done before. Now you know what you know about Agile. So when you look at the environment that you work in, we gave an example during COVID of how it would sort of feel incongruous to plan lists in the way that we'd done previously, despite having a very turbulent workforce during that time. Is there anything else that you see that feels sort of incongruous now?
Yeah, I'm sure it's the same in a lot of workplaces, but I think medicine is still quite hierarchical.
Yeah,
and the one thing that does happen quite a lot, and I'm sure you come across the concept of the HIPPO, the highest paid person's opinion. Mm-hmm. That still is something that is strange to see, and I think it will take possibly a change of generation for those things to flatten out. But we do still see that a bit. We certainly do see the kind of the hierarchies within medicine playing out. Can
you explain that? So I'm very familiar with it, but maybe some people watching won't be familiar with it.
Insofar, there's a number of times in management meetings, and there's a lot of things that go on behind the scenes in the same in social care and clinical care. Is that what sits behind the kind of service delivery is an awful lot of meetings and service developments and conversations that sit behind all of these things, and committees that all of us have to sit on. And sometimes it can be skewed a little bit because the clinician's opinion is given significantly more weight than perhaps it deserves. But one of the really heartening things about agile ways of working is that assumption that the team is all, the team comes together to deliver something, and it's not about necessarily one person or two people or whatever. There is a real kind of team emphasis, and I must admit I've changed my way of working as a response to doing some of these things in this different way, and it can feel, medicine and surgery can feel a little bit old-fashioned in that regard. There's also, I think, that an inbuilt feeling amongst clinicians is that management and is almost something that's done to them rather than with them. Even though there is there can still be a bit of a residual them and us feeling, and quite often people are promoted into line management roles with quite a lot of responsibility by virtue of sort of time served, if you know what I mean. And there's not people with a kind of burning ambition to change things. It's my turn to pick up the baton and run the department or whatever. And most of the time, people do a really difficult job really, really well. But what I'd like to see, and this might be slightly naive, but I'd like to see that how you run your service and how you work together to run your service almost becomes part of the undergraduate curriculum for medics, because at the moment, a lot of the time, or certainly was when I went through, back in the day, when I graduated, you were judged on what would you do. The questions was always where you presented with a clinical problem. What would you do? What needs to be done? So tell me what needs to be done. What would you do with this kind of patient in front of you with a neck lump or a this or a hernia or whatever? And we are all judged and have to be accountable for our own actions. There's not a huge amount of emphasis placed on what should we do? What should the service provide? It's all about, this is my action. This has to be defensible. This is within my competence. Don't stray outside your competence. You've got to, and that's clearly important. But what I'd really like to see for the future is an increased emphasis on team working. And that sounds very woolly, but
I don't think so at all.
I think that's where the big breakthroughs can come. It really does.
Yeah, I don't think that sounds woolly in the slightest, because particularly the continuous improvement work that you were talking about, everybody's got a slightly different perspective on what's happening there. So it's illogical to assume that one person is going to be able to observe all those problems and come up with the solutions. That's not the kind of problem that we're dealing with. I suppose for that team, I suppose for a change in the way teams work together in the context that you're working in to take place, and taking into account the hierarchical nature and the HIPPO effect and all the stuff that we've been talking about, I think there probably needs to be a bit of a focus on, I guess, psychological safety and people being able to say, well, actually, this isn't working, or we could have done this better. Yeah. How are you thinking about that in the teams that you're working in?
Yeah, I mean, I think that's really interesting, and that is getting better. Certainly with the younger consultants that are coming through, they are more attuned to those kind of things. So you do hear the term sort of psychological safety mentioned, and people do speak up. One of the pleasures of being an older consultant now is that stuff that you've done, however many dozens of times, is new to your trainees. So you get trainees that come in and they're like, wow, that was great. And you kind of, really? Yeah. And that next generation, the Gen Z or whatever, is that what they're called? So. Coming through are refreshing in that regard. They really are, and they're a pleasure to work with. So I do think it's important, and I absolutely agree with you that one person's solution can't can't be taken as gospel. This is why I always find it so funny when people talk about the NHS, and the first response that anybody says is, well, get rid of all the managers, all the middle managers. You've left the consultants to their own resources. I mean, have you ever met a bunch of them? They would be fighting like rats in a sack within hours. You know, you leave the consultants to organise you wouldn't leave them to run a lemonade stall or something like that. Everybody's got a different opinion, and it's largely anecdote. And this is what surprises me again. I'm being very rude about my colleagues, but quite often people are super scientific about their work.
Yeah.
And they'll say, I can't do that because there's no evidence, but show me the evidence. Blah, 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 blah. And then something about how they work comes up, and they'll say, oh, it's obvious. It's obvious we need to employ 3 new consultants. It's obvious that we need an extra wing that does this, that, and the other. And it's not obvious. It's absolutely obvious from your perspective, but what you don't see is the fact that there's a massive backlog in this particular part of it. People, they're not used to thinking in terms of flow, particularly. They just see the little bit of the pathway that they've got in front of them, and the solution, table thumping. The solution is obvious. We need to do this. We need to do that. And too often we've kind of gone, well, it's usually he's got the loudest voice. Let's let's do what he says, and lo and behold, it doesn't actually work because it was never the full story. Exactly what you said in the first instance.
Yeah, that's really interesting. Let's talk about some other opportunities to wrap it up. You've identified some opportunities within your own control for self-organizing agile teams to make improvements. Looking from a sort of slightly more helicopter view, if you were allowed to tinker with other parts of the NHS where you'd like to do some agile working, test and learn, what would be some of those areas? Where would you go?
It's very interesting to say, because when we started working with the MOD, and we haven't worked particularly closely, but they've been really helpful. And we've got some sort of commonality with some guys that are working with them, and also we're working with us. At that meeting, that is when we had the webinar, and we were talking about, well, how do you go through agile transformation? And when I was chatting to JJ Sutherland, I was saying, do you start at the bottom or do you start at the top? He said, well, you've got to do both. And I was okay. And we were talking to Mike Waring, and we were talking about how you introduce agile at scale. And he kind of, sucked his teeth and went, I said, well, the difference is, he said, in the military, we've got these things called orders, and they really help. And so it helps the military that General Jenkins, first Sea Lord, read the Red Book and then phoned up JJ Sutherland and said, we're doing this. And all of a sudden the military is doing this, and it's working for them. There's no equivalent of that in medicine. There absolutely isn't. So the way we've gone about things is from the bottom up. We've started doing the Agile for One, as Matt would call it in his trainings, and that's really helped people, surprisingly so. The fact that just that discipline of doing, creating a backlog and being realistic about what you can achieve by sizing the tasks seems to resonate with a lot of people in healthcare that are pushing themselves too hard, if honest. So I've got the emails from people who've done the course and said, I just need weeks, sometimes months down the line. The word overwhelmed is the commonest one. If you added a word cloud, overwhelmed would be number one, would be biggest, because people say this has helped me to feel less overwhelmed. So in terms of what you could do, I do think there's a role for the kind of skills and techniques of agility for individuals. I think that would help. Well, certainly, having taught the course, that helps a lot of the people that come through. And then I think actually, I think on practical terms, I'll tell you how I think it will go, because the NHS is not this kind of homogeneous organisation. There's pockets of places with issues and places with less issues. It's really different. So you get certain places that are, overperforming, certain places where they really struggle. So if we can show that using agility as a model in theatres will move the dial in our trust, which I should say is an outstanding trust according to CQC ratings. Really good place to work, very forward looking. So perhaps it's not the right place to start because we're actually starting from a really good base level, but I still think we'll show some improvements. There will be pockets elsewhere. So I don't know, but there'll be in this area, the urology will have a massive waiting list. And if that area, it's eyes, and in somewhere else, it's knee surgery, and for various historical reasons. I think there will be targeted approaches to see if this kind of approach can work in those small areas, and then I think it will go from there. There'll be pockets of good practice. We've already using the AI that we're piloting at the moment. We're already talking to, and this is just by word of mouth. We're already talking to trusts in South Yorkshire, Wales, and other places within the Northwest who've just heard about what we're doing and are curious. So I think that's the way it's going to go.
Well, I think word of mouth is selling yourself short somewhat, because I think part of what's going to make it possible for other people to have the confidence to experiment is hearing stories told in a language that makes sense to them. And I heard about your work through John Dolman, a chap who works does great work down in Somerset. So the story of your work has sort of whipped around the country, found its way to me, and it's finding its way to other people too. And I think that continuing to tell those stories is what's going to create the conditions for other people to experiment. So I think you're doing really important work, obviously in your day-to-day practice, but also for making the way for other people to experiment with agile ways of working in the NHS. So.
Well, I have to say I'm inspired by your work as well. Like I say, outside of, you probably don't realise how terrifying the work that you guys do is to the non-specialists. So fair play to you, and I've been really encouraged by some of the stuff that I've heard from you guys as well. It's been a pleasure.
Thanks, Rob. I really appreciate it. Thanks so much for agreeing to do this today.
No worries, appreciate it.